Thank you, Jack, for the introduction, ladies and gentlemen, dear colleagues. Indeed, I'm happy to give you the perspective of nurses and congenital cardiac care associates regarding the top 10 challenges after saving lives. And when I would like to find the answer on the question, what are the top 10 challenges? I either could sit in my office on my own and speculate on what this could be, or I could contact my international colleagues of nurse specialists, nurse practitioners, and physician assistants. And this is what I did. And they sent me a list of things that they considered to be their challenges. And this is the top 10. But when you have a closer look at this, you can see that we can categorize them into three main domains. The first domain has to do with improving clinical care. The second with organizational aspects. And the third pertains to professional development. And it is good that we can categorize it into three domains because all simple things come in threes. So first, let's elaborate on improving clinical care. And the first challenge is empowerment of patients and families. There are numerous studies conducted on the level of knowledge of patients, adult congenital heart disease patients. And the findings of these studies are consistent in a way that these patients have significant gaps in their level of knowledge, and mainly regarding the heart disease, the reasons for lifelong follow-up, symptoms of deterioration, endocarditis, sexuality, reproductive issues, and inheritance. And that's the reason why numerous centers have hired nurses and CCAs to educate the patients. And is this effective? Yes, it is. These are data from our center, and we have compared the level of knowledge in patients who did not previously receive any education, and the mean knowledge score was 43%. And we compared this with patients who received education previously, and their knowledge score was 57%. And even adjusting for other confounding factors, we found that patient education still is effective to increase the level of knowledge in our patients. But 57%, we are not there yet. Still a long way to go. Therefore, we know that we need to further improve patients' level of knowledge, and we have to look for alternative forms of patient education. And we think that ICT can help us. But we need to go beyond patient education. We need to empower patients and families to make them responsible for their health and healthcare. And this is the way how we can make them adherent to the medication and lifestyle advice. And how can we do it? We should expand our approach from a focus on education towards a focus on self-management. Shared decision-making and patient participation is critical in this respect. We need to build up a partnership with our patients and offer resources to patients and families. The second challenge is psychological comorbidity and psychosocial functioning. We know from numerous studies that the psychopathology in our patients is quite high. And this is also illustrated by the work of Adrian Kovacs, who found that 50% of our patients meet the diagnostic criteria for at least one lifetime mood and anxiety disorder. So we cannot neglect this issue. But there are also other aspects regarding psychosocial functioning that received increasing attention, such as romantic relationships, marital status, employability, insurability, and so on. So what to do? Well, we think we should further reduce psychological comorbidity by implementing psychosocial support systems and psychological interventions. And we could do so by starting with a formal and systematic screening of psychological issues. But again, here we need to go beyond psychopathology and social integration. Rather recently, we are starting to get some insight in the impact of family dynamics, parenting, and identity formation on the outcomes of our patients. So we need to expand the research base to get a better understanding of how this is playing a role on our patient outcomes. The long-term consequences. Patients are living longer and longer, and they show up with consequences that we are not always prepared for. And these are just some examples. Ischemic heart disease. We know from studies that 80% of all the ACHD patients have at least one coronary artery disease risk factors, and this is already present in the second decade of life. No surprise that the prevalence of myocardial infarction in ACHD patients is higher than in the general population. And both the atherosclerotic risk and antihypertensive drugs makes that a lot of male patients with congenital heart disease present with erectile dysfunction, as shown by the studies of Cook and Vigel, even in young patient groups. Menopause, what is the impact on the congenital heart disease, or in what sense the management should be adapted? All open questions, and we think this is a challenge for us. Emerging population. Over the past decades, new technologies, new treatment options have been developed, and some of them are resulting in new patient populations. And again, we do not have an extensive experience in dealing with these patients. What to do with grown-ups with hypoplastic left heart syndrome? What about transplantation in Eisenmenger patients? Patients who are treated using hybrid approaches, the geriatric congenital heart disease. So all emergent population, and we need to expand our expertise to take care for these new populations. End of life, that's another issue, and this has been neglected for many years. Indeed, the first publications on end-of-life issues in adult congenital heart disease were published in 2012. And this is a study done by Daniel Tobler and the group of Adrian Kovacs. They surveyed healthcare professionals and patients about end-of-life issues. And as you can see here, on the question, do you discuss end-of-life issues with the patients? 50% of the healthcare providers say yes. 1% of the patients say yes. So there is a discordance in the findings. And for patients, it is irrespective the level of complexity that end-of-life issues are important indeed. Also, patients with simple defects think it is important to discuss end-of-life, whereas healthcare workers are more likely to discuss it with patients with a great complexity and to a lesser extent with simple defects. When to talk about end-of-life? Patients prefer to discuss this before getting sick while healthy, whereas most healthcare providers are doing this when the first diagnosis of a life-threatening illness or condition is made. So these studies call for an increased communication with the patients, an early communication with the patients, and an implementation of the principles of palliative care in ACHD. And again, this is challenging for many nurses and CCAs. So let's come to the second domain, being the organizational aspects. And the first challenge in this respect is transfer of care and access of care, and the previous speakers have addressed this issue as well. We all know that in congenital heart disease, there is a phenomenon of care gaps, and for several patients, this results in a definite loss to follow-up. From the literature, we learned that these care gaps or loss to follow-up ranges from 21% to 76% of adults that are lost to follow-up. More recently, in our own center, we found a care gap in only 7.3%, which is substantially lower than the other reported figures. And some people say, well, this is probably due to the universal healthcare that you have in Belgium. Well, I don't think that is the only answer, because prior studies were also conducted in countries with universal healthcare, such as Canada, Germany, UK. So here you see also in countries with universal healthcare, care gaps are an issue. Other healthcare systems probably play a role, such as access to ACHD programs. This is a screenshot from the ACHA website, and this is the distribution of ACHD programs in North America. And indeed, you see that there are some underserved areas in North America. Other healthcare system factors could be co-payment. What is the proportion of out-of-pocket costs? What about the training for pediatric and adult congenital heart disease cardiology? Regarding organizational factors, what about sharing medical records? This could play a role. This could facilitate the transfer of patients. The impact of transition programs or transition clinics, transition coordinators, and what about a mandatory transfer policy? All open questions, and this is indeed an understudied area. Next challenge is recruiting and retaining ACHD professionals. How do we recruit the stellar nurses and cardiac care associates? Do we rely mainly based on their cardiac care experience, or do we rely on interpersonal skills? Or is our recruitment based on having the spirit, the so-called X factor? And I can say that I mainly rely on the last component to select my coworkers. And then, how can we retain these stellar nurses? Well, I would advise offer partnerships, offer collaboration. Let them shine, give them a place under the sun as well, and give them exposure to other colleagues, other international colleagues. So being at a conference like this is the perfect way to do so. Then I come to the last domain, being the professional development. And role development is the first challenge in this respect. And one aspect of this is training of ACHD nurses and CCAs. So far, a formal curriculum for ACHD nurses and cardiac care associates is lacking, and we would benefit from it. Both educational institutions as healthcare institutions would benefit from such a curriculum. Do we need an internship? Yes, we think so, but how to organize this? How to implement this? And what about research training? Should this be part of the training? Yes. How extensive this should be, and so on. Second aspect in role development is how to demonstrate your value. So far, the empirical evidence on the impact of nursing and CCAs on the outcomes is still limited. No surprise that this issue has been put highly on the research agenda. Multiple forces are acting upon nurses and CCAs. Some of them are driving forces, others are pulling forces. And these forces are coming from the nursing department, from physicians, from hospital administration. How to deal with it. And the final aspect of role development is a model of collaboration. Do we as nurses and CCAs work in substitution of MDs? Do we replace the MDs? Or do we work complementary to MDs? From the empirical evidence so far, we learned that working complementary, advanced practice nurses working complementary with MDs result in better outcomes than only working in substitution. And therefore, we prefer to work complementary with the MDs. And furthermore, we want to avoid that the cardiologists end up in this role. Funding. Well, we are all faced with restricted budgets, and the current financial climate is not very positive. What is the business model? Can you charge directly? Is there no direct charge? Do we depend on soft money and so on? And therefore, what is the feasibility on the long run? And the last challenge that was proposed is bringing the CHD paradigm to other disciplines. Indeed, how can we inform healthcare providers of other disciplines about ACHD issues? Our colleagues from the cardiac ward can be panicked when they see a patient with a hematocrit of 62%. But in fact, it's perfectly normal in an asymptomatic Eisenmenger patient. Or what to do when the blood pressure is not measurable in the arms. What could be the reason? Well, again, it's perfectly normal in patients with tetralogy of Fallot with shunts at both sides. This brings me to the conclusion. These were the top 10 challenges for nurses and CCAs, and we can categorize them into the domains of improving clinical care, organizational aspects, and professional development. Thank you very much.